I'll turn it back over to Rob, where he's going to talk about women's health.
Okay, well, I'm back again. We get to talk about another topic. This is a topic near and dear to me. I've devoted most of my life to engaged in treating women in my practice in OBGYN. I was actually surprised in medical school that I ultimately chose that as my area of specialty. But what I found in treating women patients and what I found about the specialty of OBGYN was that it involved a variety of elements of medicine. It involved primary care, it involved surgery, it involved endocrinology, it involved understanding coagulation pathways, it required an intense understanding of pelvic anatomy for surgical interventions and for managing obstetric patients. So there's a lot involved in taking care of women. Women have got the history of care for women is an intense one. We think about the problems that are generated specifically with childbirth and how it has generated a number of advancements in medicine. And so we see in so many elements of medicine that when we have a problem, we are forced to rethink it, understand more about it, to move things forward. We're going to talk today about the applications of molecular technology to the care of women and how we can move things forward to help the practitioner make appropriate diagnoses so patients can be treated in an effective and certainly a cost-effective way, which is increasingly important in the environment in which we live. And we're going to talk about, first we'll talk about HPV. HPV is a circular double-stranded DNA virus, 7,900 nucleotide base pairs. More than 100 have been fully sequenced. 20 million people are currently infected with HPV, and 80% of women have acquired an HPV infection by the age of 50. I think that's an incredible statistic. It's important to understand that the presence of HPV in the environment it's everywhere. It's truly ubiquitous. And as we're beginning to understand how HPV contributes and causes cancer, we're understanding to a greater degree that HPV is involved not just with the genesis of cervical cancer. It may be involved with the genesis of lung cancer. We know that it's involved in the genesis of cancers of the oropharynx, cancers of the vagina and of the rectum. I suspect that over the next 10 years we're going to appreciate its role in a variety of other disease states that we have not even considered today. Now, one of the amazing things that happened was the advent of the pap smear. And the pap smear has changed so much over the last 50 years. In developing countries, it has had a huge impact on the frequency of invasive cervical cancer. And obviously that is a very good thing. But one of the things that happened is initially when we started doing pap smears, we took cellular material and placed it on a slide. It was fixed. And then we looked at that slide and we made our assessment from a relatively difficult looking slide. And the technology changed and we started using liquid-based cytology. And once we started using liquid-based cytology, we could start looking really at HPV in a much more effective way. And as we started to understand the impact of HPV on the genesis of cervical cancer, we began incorporating this in terms of understanding what the power was of surveying patients for HPV. I think this graph tells us the most about the power, the predictive power of HPV surveillance. If you look at these two lines, this is the line. There were about 20,000 patients that Dillner looked at. This was published just a couple of years ago. These patients underwent one assay, and then those patients were followed over 72 months over time. You saw that, bottom line, the blue line represents cytology alone. Patients who undergo cytology, the only thing that we have really ascertained about that patient is what's going on a cellular level in the cervix at that moment in time. It doesn't tell us about what's going to happen in the future. But when we understand that HPV causes cervical cancer, if we can assess whether the person has an HPV infection, we can make a prediction about the likelihood of that person developing cervical cancer over a relatively extended period of time. So in this study, 72 months or 6 years we looked at, if you if the patient was HPV negative, we really got a value that extended out a very, very long time. So it is the predictive nature of HPV infections that, of HPV assessment that gives us a much stronger tool in terms of diagnosing and preventing cervical cancer. Now, so we understand the power of HPV generally, but we're also understanding that genotype has a significant impact on terms of the way we manage patients and the way we understand infections. We know that types 16 and 18 behave differently than other high-risk types. We're beginning to understand that discrimination between persistent and new infection requires a knowledge of genotype, and that following persistent type-specific infections can be a central part of management, because it is the patients that are unable to clear a specific HPV infection, or those are the patients that are at greater risk for developing cervical cancer. Also, as we are beginning to use and we have Gardasil, the quadrivalent vaccine, it's important from a public health standpoint for us to be able to monitor the genotype prevalence within a population to understand what the impact of our immunization programs are having and to look for the emergence of new viral types that can be significant. Now, this is Michelle Kahn's work that really, I think, does a very good job in describing what is going on with patients that have type 16 and type 18 infections. She's looking at the incidence of CIN3 in patients over a 10-year period. And we have, if you look at the top line, this is the incidence of CIN3 for patients that have a HPV 16. And you look at the next line, that's the incidence of CIN3 in patients with type 16. The lower lines represent those patients that are just generally HPV positive. So with this information, if we're able to actually assess whether 16 or 18 is present, we have now moved to change our management on those patients. And because we have the technology and that technology has been readily accepted and is accepted at this point, we have now integrated our algorithm so that if a patient has type 16 or type 18 at their evaluation, they go directly to colposcopy. And that is a very different way of managing patients, and that really shows the significance of 16 and 18 in terms of intervening early, because there's a very high likelihood that those patients may have a CIN2 or a CIN3 that requires treatment. Now, we've looked at 16 and 18, but it's important to note that there are really 12 other high-risk types that are significant. What makes those types significant is if the patient is unable to clear those high-risk types. So it is the inability to clear an infection over time, which is really an indicator of whether a patient is at risk for developing cancer. She looked at over 22,000 women, 41 studies, and HPV persistence was validated as a clinical marker and endpoint. So if we're looking at a patient who has a specific, let's say HPV 35, she's got a 35 infection and she is unable to clear that over 12 months, over 18 months, or 24 months, and we need to be really concerned about that patient in terms of whether she has something that we've been unable to identify. It's important to understand that when you're evaluating the cervix, cervical cancer can be a multifocal disease. It can be a process that exists up in the endocervical canal that is difficult to evaluate. So those patients may be very problematic. So it's important for us to be able to focus our resources on the patients that we're most concerned about. Now, in terms of separating out patients that we're concerned about and patients that we don't need to be concerned about, it's important to understand how we can use the genotyping to aid us in this result. If we look at this study that was done in Costa Rica, 10,000 women were followed, and they were followed over time with both an HPV test, but also with genotyping. They had genotyping done every year. Now, for the patients that had persistence, that is, they had a type 18, they had it for a period of time, and they continued to have it for a period of time, we look at what the incidence of CIN2 and the incidence of CIN3 are. Those are patients that are HPV 16 or HPV 35. It didn't matter what type. If they were persistent with it, they were at risk. Then we look at patients that are what they call here positive. Those are just patients that are HPV positive we usually talk about the Digene assay, hybrid capture 2. Now, you remember what I said before, HPV is ubiquitous. Patients get reinfected all the time. A patient that has type 35 and then develops a 16, I'm certainly still going to be worried about that patient, but that patient has proven to me that she is not immunocompromised. She is competent to clear one virus, and she may get another infection. This may be a sexually active person in her mid-30s, and she is at risk for having a reinfection. But there is a dramatically different risk associated with a reinfection when you've shown the ability to clear one than a person that is unable to clear the initial infection. So what is the risk of a person that clears one infection and then gets a new infection? Well, the key element of this is you look at the bottom line. And although this is not a large sample size, only 51 patients were found in this study. But the incidence of cervical cancer, if you can show that you've cleared one infection and you may have another infection, is 0. When in doing scientific research, when you start seeing lines like this, these kinds of curves, and then you see a completely flat line, that is an important discriminatory marker. So we believe, and I think and the people that are engaged in HPV research, that type-specific persistence is extremely important. Every high-risk type is significant if it is not cleared over time. And evaluating persistence requires type identification at an initial point in the workup. And important pooled data does not differentiate new infections from persistent ones. And identification of type, I think, also makes sense in dealing with patients. Makes sense to the patient and to the practitioner in terms of understanding what process is going on with her. Now I want to move on to another topic. We're going to